morning, good evening, everyone, and welcome to another CanVector National Thrombosis Seminars. I'm Dr. Agnes Lee. I'm a hematologist in Vancouver, Canada, and welcome. For those of you who've joined us before, you know this is a seminar that we have set up with two speakers covering timely and controversial topics in thrombosis. And these are monthly seminars, and today, will be our second last one of the year. We'll have one more in May. And all of these seminars are recorded and will be available on the CanVector website in case some of you may have to leave early or haven't been able to attend. And I would certainly encourage you to visit the website for previous seminar recordings as well, because they've all been really outstanding talks. I want to thank our planning committee who listed here, who have helped to organize the talks and invited speakers. And we've been really fortunate to have had, again, outstanding speakers both nationally and internationally covering a broad type scope of topics. For today, we're going to be looking at bleeding and anticoagulation. And again, two amazing speakers who's going to talk to us about something very practical, and but bringing all the science behind it as well. So we're going to have Dr. Lana Castellucci, and she's going to be presenting her ongoing study right now, funded by the CIHR, called COBRA, comparing the bleeding risk between rivaroxaban and apixaban for treatment of acute venous thromboembolism. And we're thrilled to have Dr. Bethany Samuelson-Bano, who's going to talk to us about DOACs and heavy menstrual bleeding. So again, very important practical topics. There will be a 15-minute Q&A period at the end of both presentations, and I encourage you to submit questions anytime throughout the seminar, but please use the Q&A function, not the chat function, all right? And I will be sort of curating them throughout the talks, but then we'll be addressing all of them at the very end. And so without further ado, I want to introduce Dr. Lana Castellucci. Dr. Castellucci, she is an assistant professor in the Faculty of Medicine at the University of Ottawa. She is also an associate scientist at the Ottawa Hospital Research Institute. She completed internal medicine training at the University of Ottawa, a fellowship in critical care medicine at the University of Calgary, followed by a clinical and research fellowship in thrombosis with a master's in clin epi at the University of Ottawa. Dr. Castellucci, thank you.
Thanks very much for that kind introduction, Agnes. Caleb, I'm sorry, I don't know what I did to the slides. Thank you. So thanks everybody for having me today. It's my pleasure to talk about the COBRA trial, and I'm excited about this study as we have incorporated many of our partners right across CanVector in this trial, and so it's a great collaboration that I'm really excited about. So as Dr. Lee mentioned, this is comparison of bleeding risk between rivaroxaban and apixaban in patients with acute VTE. In terms of my disclosures, there's nothing relevant for today's discussion, and we will talk about VTE and how it's related to Canadians, the treatment of acute VTE, looking at both direct oral anticoagulants and comparison to warfarin in our seminal phase 3 trials, with a particular focus on safety and the limitations of those studies. And then we'll delve into the logistics of the COBRA trial. So as you all are aware, VTE is very common. And we look at some administrative database information collected from Alberta with 6 large administrative databases with information of over about a decade, so 10 or 11 years between 2002 and 2012. And they've nicely broken this down into age categories as well as by sex or gender. And we're all very much aware that our risk of VTE increases both with age as well as different stages of our lifetime from a gender or sex perspective, with women in the younger age groups being at a greater risk because of things like use of oral contraceptive pills, pregnancy, and the peripartum time frame. And overall, from this information, we know that the risk is about 1.4 per 1,000 person years, and that translates into maybe 50,000 Canadians per year being diagnosed with VTE, PE, and deep vein thrombosis. And so this is important information for us as Canadians because it also impacts morbidity and mortality outcomes. And we know that the treatment of VTE is oral anticoagulants, and it's great at reducing risk of recurrent thrombosis by more than 90%. And we're also very much aware that in the last decade, direct oral anticoagulants have really become the mainstay of therapy. And in North America, the most commonly prescribed agents are apixaban and rivaroxaban, primarily because they don't require low molecular weight heparin lead-in. And so this is a really important piece of information as to why we are looking at these agents for the COBRA study. And of course, in addition to the RCTs, there's also large database studies that would potentially suggest apixaban is a safer direct oral anticoagulant to use. However, we know that there are some limitations that I'm going to talk about in the next coming slides. So when we look at direct oral anticoagulants and rates of recurrent VTE, we always need that baseline as a comparison to understand where the information came from. When we look at the RCTs, I'm going to be talking about Amplify, which evaluated apixaban compared to enoxaparin and transition into warfarin, as well as the Einstein series, which had the 2 trials for VTE, as well as a separate pulmonary embolism study. And when we look at the Einstein series, again, rivaroxaban was for the acute treatment dosing of 15 milligrams twice daily for 3 weeks, followed by 20 milligrams once daily, compared to enoxaparin and warfarin with that INR target of 2 to 3. And in the VTE trial, what we saw was that the rate of recurrent thrombosis was 2% in the rivaroxaban arm and 3% in the warfarin arm, which was non-inferior. So all of these trials are non-inferiority studies. And this was very reassuring data, which allowed us to really adopt this into clinical practice. And similarly, in the PE studies, we see very similar rates of 2% and 1.8%. So again, very reassuring data. When we look at the apixaban or Amplify trial, what we see is similar rates of recurrence of 2.3% and 2.7%. So again, rapidly adopted into clinical practice. And people are always interested in how does this information translate into the real world population? Because I think we're always aware that randomized control trials are somewhat selective in terms of patient population. And so many people have looked at healthcare claims databases, which are large databases taken from the US, and tried to determine what are rates of recurrent VTE in select patient populations. And when they looked at the market scan group, this particular paper reported that rates of recurrent VTE happened in 7 per 100 person years for rivaroxaban, and just under half of that for apixaban. And what they suggest is that apixaban is the best agent at reducing risk of recurrent thrombosis. Of course, whenever we're looking at recurrent thrombosis, we always want to balance that with bleeding event rates. And so when we look at those phase 3 trials and we talk about clinically relevant bleeding, which is a combination of major bleeding and clinically relevant non-major bleeding as defined in these studies, what we see is that in the Einstein DVT trial, the rates of clinically relevant bleeding were identical. And in the PE study, very similar, so 10% versus 11%. But the important difference was really seen in the Amplify trial with apixaban. So apixaban patients had a combined bleeding event rate of 4% compared to nearly 10% in the warfarin arm. And so that was very statistically significant. And again, it leads many people to believe that it is a safer drug and should be used preferentially over rivaroxaban. When we go back to the same healthcare claims database studies and we look at particular bleeding events that they defined in their study as major bleeding, which included GI bleeds, intracranial hemorrhage, and the large catch-all of other. These events were identified on ICD codes, and so these events are limited. They're not adjudicated events, and so we are limited with what is reported in these healthcare databases. But again, similar to the recurrent VTE rates, we would see that patients on rivaroxaban had higher bleeding rates compared to those on apixaban. And so again, this study suggested that apixaban should be used preferentially over rivaroxaban when treating for VTE. Several years ago, our group in Ottawa did a network meta-analysis of 45 studies evaluating treatment of acute thrombosis, and this included both RCTs with different drugs and drug combinations. And what we did here was in the table, in the forest plot here, what you can see is that our comparator is low molecular weight heparin and warfarin, because at the time that we did this analysis, that was still the standard of care therapy. And so all other treatments are compared to that combination. But what I want to highlight for you are the agents of rivaroxaban and apixaban. And in bluish color here, you can see that for recurrent VTE, both of these agents cross unity, and so it suggests that they're as good as warfarin, which is what we see in the phase 3 trials. But when we pooled all this information and looked at bleeding event rates, there was a signal that rivaroxaban was associated with lower bleeding event rates and more so with apixaban. So again, this is where the idea of trying to determine what is the best agent led to the idea of the COBRA trial. And what we want to try to understand with the COBRA trial is why are there differences in the bleeding event rates that are reported in the phase 3 trials and also in the healthcare database studies that are reported. And there are limitations to those phase 3 trials when we look at patient populations, for example. So it's a heterogeneous group with the Amplify series, including mainly patients with unprovoked VTE, and the Einstein series, including both provoked and unprovoked VTE. The eligibility criteria are also very different, with those for the Amplify trial being far more stringent. So patients with recent bleeding, for example, were excluded from the Amplify trial, and they also had different thrombocytopenia thresholds that they excluded patients for. So of course, this also leads to changes in baseline bleeding risk when you start to exclude patients from participating in these trials. Other key differences for these phase 3 trials are related to treatment duration, with Einstein being related to a physician choice of anywhere between 3 and 12 months of treatment, whereas Amplify was standardized at 6 months for all, and probably because it was an unprovoked, primarily an unprovoked patient population. And then, of course, the trial design is something that needs to be acknowledged as well. So Amplify is a double-blind RCT, whereas Einstein series are open-label RCTs. And as we know, when patients may be aware of what they're taking, they may be more likely to report event rates. And so that may be why we're seeing more bleeding event rates reported in the Einstein series than with other similar trials. So as I said, this is what really led to the idea of the COBRA trial. Why are these differences in bleeding event rates being seen between these two phase 3 clinical trial platforms? And so we're looking at a difference of nearly 50% when you look at just the raw numbers of 8% in the Einstein group and 4% in Amplify. And so we designed COBRA, which is a pragmatic study of probe design. So prospective randomized open label blinded endpoint design to evaluate the superiority of apixaban over rivaroxaban for a 3-month treatment period for clinically relevant bleeding in patients with acute VTE. And our primary outcome, of course, is that 3-month cumulative rate of the combined bleeding event. And our events are going to be adjudicated as well as defined by the current ISTH criteria, both for major bleeding and clinically relevant non-major bleeding. Patients will be randomized 1-to-1 to either apixaban or rivaroxaban according to the treatment dose for acute VTE. And all patients are going to be treated and followed for 3 months. We chose 3 months for 2 reasons. One is that this trial will include patients that have both provoked and unprovoked VTE. And the recommended treatment period is minimum 3 months in each of those categories. And of course, the other reason is that you don't always get as much money as you ask for from CIHR. And so that limits how much time we can follow patients for. And so we do have a 3-month follow-up for all patients instead of out to 6 months for patients with unprovoked VTE. And in terms of how we decided on our sample size, so this is what we looked at as our minimal clinically important difference in how to inform our decision making. And we determined that although in the studies you saw perhaps a 50% difference in bleeding event rates reported, we thought that we wouldn't need perhaps that high of a difference to lead to a change in clinical practice. And we thought that a risk reduction of a third in that 3-month period would be meaningful enough for us to change our practice. And so that resulted in an MCID of 2.7%, and it would really be sufficient to support recommendations for use of apixaban over rivaroxaban for superiority. So this sample size ends up being quite large at 1,380 participants per arm to have 80% power to demonstrate that 33% risk reduction over 3 months. And it's a two-sided alpha. So further to this, when we designed this, we moved forward with a pilot study, and this was a pilot that was funded by CanVector and allowed us to do some really unique things. So what we were able to do with this pilot study was include 4 sites, 2 of which were established research centers, being Ottawa and McMaster, and then 2 newly or emerging research centers, which were Sherbrooke and Edmonton. And so between these 4 sites, we were going to recruit 72 participants over about a 6-month time frame. And again, this was a pragmatic probe design, very similar to the full trial. And other things that we looked at in the pilot study included medication adherence. And at the Ottawa site, we used 3 different methods with medication diaries, pill counts, and electronic cap devices on bottles. And at the other 3 sites, we did medication diaries and pill counts only. What we had for our eligibility criteria for the pilot study are the same eligibility criteria for the full-scale trial. So the inclusion is patients that are diagnosed with acute symptomatic proximal DVT or pulmonary embolism that is segmental or greater on imaging, and patients are excluded for the reasons on the right-hand side. And although this list may appear long, I can assure you that it is much more practical and pragmatic than compared to the exclusion criterion for each of the phase 3 trials. And really the big things that we want to highlight are we exclude patients that have received more than 3 days of anticoagulation because those are patients that are close to reaching steady state for treatment, and we don't want to include those patients. Anybody who has significant renal failure with clearances less than 30, another reason to be on anticoagulation such as atrial fibrillation. And at the time the study was designed, we excluded patients with weight more than 120 kilograms based on the recommendation from the ISTH SSC. And we also exclude patients with bleeding active malignancy as defined by the Hokusai cancer trial, and of course, women that are peripartum and breastfeeding. And then we also exclude patients that are on contraindicated medications that are strong inducers or inhibitors of the DOACs. So in terms of results from the pilot study, we were able to achieve feasibility and recruit our 72 participants. The target that we set out for was 3 participants per month per center. And what you see here is that Ottawa was able to recruit in 4 months approximately 40 patients, and each of the other sites approximately 10 to 11. So that was really fantastic work from all of our sites. And so what we set out for was 3 patients per site, and what we achieved was 4 patients per month at our experienced sites compared to 2 patients per month at the less experienced research centers. But this was really informative for us to allow us to look at how we can best support these new and emerging centers coming up to participate in our clinical trials. So then we moved on and we were successful in achieving CIHR funding for the full sample size of 2760. And as I mentioned before, we are utilizing all of our sites across the CanVector networks, which is really exciting. This is a phase 4 study, and so it is meant to be very pragmatic and to follow up with our clinical practice and not ask a lot more in terms of patients with follow-up expectations. And this slide demonstrates all the logos from our participating sites. And so this is really fantastic work that we have as a group of researchers across Canada. And this is just a different schematic view of the COBRA design. And so eligibility criteria here with our adult patients with acute VTE that are randomized 1-to-1 to rivaroxaban or apixaban. And they are followed up at 2 weeks, either in person or more commonly now by telephone, since all of our work has really shifted to virtual work, as well as the closeout visit at 3 months. In terms of the outcomes, so our important outcomes that I mentioned, the primary outcome is that composite of major bleeding and clinically relevant non-major bleeding defined by ISTH. And the secondary outcomes are listed here, which each component of the primary outcome, as well as adjudicated recurrent VTE and VTE-related deaths, all-cause mortality. We are also evaluating medication adherence, and this will simply be done by questionnaire to the patients. And importantly, as part of our bleeding events, we are going to be evaluating women of childbearing age and asking about heavy menstrual bleeding as part of it. And we'll have some great content on that from our next speaker. So I'm excited to hear about that. We are also going to be doing a cost-effective analysis as part of this information. And so we will be collecting questionnaires from participants so that we can determine what the cost effectiveness is overall for Canadians. So very recently, we were able to collaborate and move more on an international platform. So I'm really excited to say that COBRA is now collaborating with a group of Australian researchers. And we were very fortunate to receive some seed funding from the Invent group, as well as the NHMRC for some ongoing funding to support incorporation of about 12 to 15 Australian centers to include them in COBRA. And these are centers that are participating in the FANS network, which is the CanVector equivalent in Australia and New Zealand. Now, unfortunately, we are not able to have any New Zealand sites participating because they don't have both DOACs on their formulary. They only have one of them available. And so we weren't able to include sites from New Zealand, but all of the sites in Australia do have access to both apixaban and rivaroxaban, which is what allows us to have this great collaboration. And our co-PI in Australia is Dr. Vivienne Chen, who is based out of the University of Sydney. And she has really spearheaded this, and in conjunction with her group at FANS, we were able to invite all of these sites and investigators to participate in the COBRA trial. And at the end of March, we were really excited. We recruited our first Australian participant, and we have 2 sites in Australia that are now recruiting. And I think we have 4 or 5 patients that have been recruited so far since the end of March. So this is a really great start. And we have several sites that are in the process of being initiated, and some other sites that are working through their REDs for startup. Some interesting sub-studies that will come out of the Australian work includes a biomarker study that Dr. Chen's group is going to be leading, as well as a health economic analysis specific for the Australian population. In terms of where we're at for monthly recruitment, so this is a tabular view that you can see over the past few years that we've been recruiting. And this is another way to look at this. And really what I want to show you on this histogram is that you can see right when COVID-19 pandemic really halted research last year, you saw that in March we were doing fairly well as expected in terms of meeting our target recruitment. And then in April and the subsequent months, we had a significant slowing. But what I'm happy to report is that since January, many research centers have reopened and allowed recruitment into clinical trials again. And so we've been able to slowly recover and work back towards our target monthly recruitment. In terms of other updates, we do have an independent adjudication committee that is being chaired by Dr. Gandera, and our members include Dr. Nianli, Dr. Barco, and Dr. Treachler, and they will be using the combined Invent and CanVector verdict platform to do the adjudication. We will be undergoing some training with them in the month of May so that we can get things moving for real-time adjudication. And our DSMB is composed of our chair of Dr. Blondin and Dr. Bauman-Kruziger and Dr. Parpia. And we had our second meeting just last week, and the recommendation was for the trial to continue without any modification. So they were pleased with how things were going, understood the the slowdown in recruitment based on the limitations from the pandemic, but did not have any concerns with our current practices. And we're excited to hear about Australia being able to offer some additional participants. So I would just like to close by thanking our research team and our participating sites, our collaborators, and our patient partners and participants, and just our funding sources. So many thanks to everybody.
Thank you very much, Lana. That was great. That was an amazing overview. And again, congratulations on really getting COBRA started, maintaining it throughout COVID. And, we're seeing the recruitment going back up. So I'm going to now introduce our second speaker. Dr. Bethany Samuelson-Bano is an assistant professor of hematology at the Knight Cancer Institute and the Hemophilia Center at Oregon Health and Science University. She's an adult hematologist with a research and clinical focus on the care of women with bleeding and clotting disorders. She is passionate about equal care and representation in research for women and all patients with bleeding and clotting disorders. She is the co-chair of the Thrombosis Committee in the Foundation for Women and Girls with Blood Disorders Learning Action Network, an organization which works to ensure all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. Thank you very much, Dr. Samuelson-Bano. It's delightful to have you join us, and we're really looking forward to your talk.
Thank you so much. I am so honored to be giving this talk. I think when I got an invitation from Dr. Lee to speak with Dr. Castellucci about my favorite topic, I think I replied yes within probably less than a minute. So I am thrilled to be here and talk about what I think is a super important topic that unfortunately often goes missed in hematology and primary care practices. So I have no disclosures. And we'll hop right in. So objectives for today, we're going to talk about the risk of heavy menstrual bleeding in patients on DOACs. We're going to identify some key time points at which we really need to recognize and address heavy menstrual bleeding in the care of patients on DOACs. We'll discuss some of the complications of heavy menstrual bleeding, and we'll learn about the management of heavy menstrual bleeding in patients on DOACs. So I'll start with a clinical case. So imagine you are seeing in your clinic follow-up a 27-year-old woman. She's reporting fatigue and restless leg symptoms, and she is in your office because she was diagnosed with a PE and a DVT 2 months ago. She was started on rivaroxaban in the emergency room, and she's here to follow up about that. Her clot was provoked. She was on oral contraceptive pills. They were stopped by the ED physician at the time of diagnosis. She denies any other kinds of bleeding. She's not having epistaxis. She's not having melena. She's not having hematochezia, but she says that her periods are very heavy, particularly since starting rivaroxaban. So let's talk about the definition of heavy menstrual bleeding. So historically, it was defined as menstrual blood loss greater than 80 milliliters per cycle, with average menstrual blood loss being about 50 milliliters per cycle. And obviously that's not something that's practical to measure in the clinic. And there's actually a much more patient-centric diagnosis that we like to use now, which is from FIGO, and we define it as excessive menstrual blood loss, which interferes with a woman's physical, social, emotional, and or material quality of life. So a nice broad definition. So what about heavy menstrual bleeding on anticoagulation? So about 30% of women will have heavy menstrual bleeding at some point. In women who are on anticoagulation, that increases to 70%. So it's super common in our anticoagulated patients. And yet, surprisingly, it's not something we talk about a whole lot. So it is underreported and underdiagnosed. And I think a lot of this is that patients are uncomfortable bringing it up, or they don't know if things are normal or abnormal. And maybe sometimes we forget to ask because we're busy thinking about other things like recurrent VTE and issues like that. But it is something that I think we're going to find a lot more of as we start asking more about it. Importantly, it can be associated with modifications of anticoagulation, either made by providers who are worried about the heavy menstrual bleeding, or perhaps even by patients who may be making these modifications without telling us about it, which is obviously very concerning from a recurrent VTE risk standpoint. So let's talk about what we know about heavy menstrual bleeding and abnormal uterine bleeding in the DOAC trials. So unfortunately, the major limitation here is that heavy menstrual bleeding is not captured well using the standard ISTH major and clinically relevant non-major bleeding diagnoses, because it is a recurring event. It happens every month. And so it's quite easy for a woman to become anemic with recurrent heavy periods. And so unfortunately, a lot of heavy menstrual bleeding, I think, is missed in these DOAC trials. But what we can see is we can look at the differences in rates of clinically relevant non-major uterine bleeding between the investigated drugs, so the DOACs, and the control group, which of course in each case was low molecular weight heparin lead-in followed by warfarin. And what we see here, the most interesting thing I think is with rivaroxaban, there was actually a twofold increase in these uterine bleeding events compared to warfarin. And as Dr. Castellucci so eloquently pointed out, in general, we expect to see less bleeding with DOACs than with VKAs. So this is a really striking number. We see similar rates with apixaban, perhaps a slightly higher rate with edoxaban, and interestingly enough, lower rates with dabigatran. Now, until Dr. Castellucci's study, we haven't had direct comparisons between the DOACs with focus on heavy menstrual bleeding. So this is, of course, you can take it with a grain of salt, but I think it is important for us to keep in mind in our clinical treatment of patients. And when retrospective studies have been done, so again, not randomized trials, they have confirmed that women on rivaroxaban seem to have worse periods compared to women on VKAs. So more prolonged bleeding longer than 8 days. And so as a reminder, a normal menstrual period is typically between 2 and 7 days. Women on rivaroxaban are more likely to require intervention for heavy menstrual bleeding, so a quarter of women compared to VKA, and also more likely to modify anticoagulation. But perhaps the most scary statistic is women who were on rivaroxaban and experienced heavy menstrual bleeding had a 5-fold increased risk of recurrent VTE compared to women who did not have heavy menstrual bleeding. Pardon me. So this does appear to be a potential risk factor for recurrent VTE, likely because these patients are holding their anticoagulation, again, perhaps without telling us. But it does, again, tell us that this is something that we need to be paying attention to in our patients. How exactly should this inform care? So I would propose to you that there are 3 primary time points at which we really need to consider the impact of heavy menstrual bleeding. So first is, of course, at initiation. During monitoring visits, and I recognize, we don't monitor DOACs the way we historically have monitored warfarin, but I would argue particularly in this population, I think we do need to be checking in with them relatively frequently just to make sure things aren't developing. And then we need to think about it as well at DOAC discontinuation. So starting a DOAC in a menstruating individual. So almost the first thing I do, which is a bit different than my fellows are used to doing with other people, is I'd like to take a menstrual history. And this is to help me find out if the woman already had heavy menstrual bleeding before starting on anticoagulation, and am I just going to make it that much worse? So signs of heavy menstrual bleeding are changing protection more often than every 1 to 2 hours, a history of iron deficiency, with or without anemia, so a low ferritin, periods lasting longer than 7 days, and if women wake up with soaked sheets during their menstrual periods. And just as a reminder, if the woman has a VTE associated with OCPs, ask about her periods before the OCPs, because they probably improved her bleeding. And when we take them away, which we will have to at some point, the periods are going to get worse. I would argue, though, that we can actually delay the discontinuation of OCP based on some data that I'm going to show you later. So other things to think about. So include the risk of heavy menstrual bleeding in your risk and benefit discussion. I think it's very common for an otherwise young, healthy woman who has a clot, perhaps due again to estrogen use. Obviously, the lead-ins required for edoxaban and dabigatran with low molecular weight heparin are burdensome. So we often, again, as Dr. Castellucci pointed out, wind up choosing between apixaban and rivaroxaban. And I think in these young, healthy women, a once-daily option is often the most practical. But I think when we have that discussion, we also need to bring up the issue of heavy menstrual bleeding and advise them that the risk may be higher with rivaroxaban and see if that changes their decision-making profile at all. We also need to be sure to discuss normal versus abnormal bleeding. I think most women don't know what's normal and abnormal when it comes to periods. So giving them some advice about when to let you know that it's abnormal is going to be very helpful. And you can actually send them to this incredibly helpful website, letstalkperiod.ca, that is run by Dr. Paula James. It has really helpful patient-centered information. So that's a good resource. I always check a baseline CBC and ferritin in these gals because often they will be iron deficient. It's very common in menstruating women. And discuss contraception. So remember that the risk of recurrent VT is higher with pregnancy than it is even on OCPs. So we need to make sure these women are on effective contraception. So at monitoring visits, so I tend to check in with these patients perhaps a little bit more often, maybe every 3 months if they're on indefinite anticoagulation, at least until things get settled out. But every visit, check in about menstrual bleeding. Ask them about the symptoms I mentioned a few slides ago. Ask them about changes in their periods to make sure that's not falling through the cracks. Again, ask about contraception. And during these visits is a good time to talk about post-anticoagulant discontinuation strategies for contraception, particularly if the woman has remained on OCPs and you're looking at ending the anticoagulation at 3 months, talking about what you're going to do after that and reminding her that, again, the risk is increased with pregnancy. So we want to make sure that we are preventing unwanted pregnancies in this population. And I would also check a CBC and ferritin every 3 to 6 months, at least early on, while you're figuring out how much blood loss she's having and if she needs recurrent iron treatment. So if you do find out a patient has heavy menstrual bleeding, let's talk about the strategies that we have. So the top recommended therapies for HMB in a general population are hormonal therapies and antifibrinolytics. Procedural therapies are, I don't want to say an absolute last resort, but they're definitely later down the line. And then in this population, you could potentially consider anticoagulant modification, although there's not a lot of evidence for that right now. So let's talk about hormonal therapies. And I apologize, this seems to have kind of come off the slide a little bit, but the main groups are combined hormonal contraceptives and then progestin-only therapies. So combined hormonal contraceptives come in the options of pills, patches, and the vaginal ring. Progestin-only therapies, we have a variety. And I apologize, I didn't update this slide with the appropriate Canadian brand names, but the levonorgestrel IUD comes in the form of the Mirena, and I believe you have the Kylena instead of Skyla or Liletta in Canada. The subdermal implant, which we both have Nexplanon, progestin-only pills, and depomedroxyprogesterone or Depo-Provera. And all of the methods that are bolded are ones that have an increased risk of VTE in the absence of anticoagulation, so ones to be aware of, but all have potential to be effective for controlling heavy menstrual bleeding. So I've already told you that I think it's okay to continue OCPs while patients are on anticoagulation. Why do I say that? It's because of this post hoc analysis of data from Einstein trials where they looked at risk of recurrent VTE in women on no hormones, any hormones, estrogen only or estrogen containing hormones, and progestin only hormones. And as you can see, the risk of recurrent VTE is identical, if not actually trending towards less, although not statistically significant, in women on hormonal therapies. So this makes a strong argument that women who are therapeutically anticoagulated are probably able to tolerate hormonal therapies as needed, including estrogen containing therapies. So what about hormonal therapy after anticoagulation? So a lot of women, a lot of patients who are menstruating are going to have estrogen-associated VTE, and we don't anticipate them to have to continue indefinite anticoagulation. So what do we do when they stop? So the IUD or subdermal implant are both safe, are not associated with an increased risk of VTE. Progestin-only pills are also safe, although less effective from a contraception standpoint. So IUD or subdermal implant is greater than 99% effective for prevention of pregnancy. Progestin-only pills comes down closer to 80%, and they have to be taken at the same time every day to really be effective for prevention of pregnancy. And sadly, I have seen more than one unwanted pregnancy in a young woman in my clinic because she was given progestin-only pills and got pregnant on them. So something to keep in mind. And again, we do want to make sure these patients are having effective contraception. So after anticoagulation, of course, we need to avoid estrogen-containing therapies and actually depomedroxyprogesterone. I think it's not necessarily well known that even though it's a progestin-only therapy, it can increase the risk of VTE in a non-anticoagulated woman. So I recommend against that as long-term contraceptive or heavy menstrual bleeding control in a non-anticoagulated woman with a history of VTE. So what about antifibrinolytics? So we know they're very effective for the management of heavy menstrual bleeding. We know that they do not increase the risk of VTE, and my favorite trial to cite when I'm talking to patients about this is actually the woman trial, where we gave it to women who were postpartum, so a very high risk time point for VTE, and saw no increased risk of VTE with TXA, or tranexamic acid. So I think it's safe in women who have a history of VTE. We don't have data on combining it with anticoagulation yet. So the Medea trial is ongoing, and they're actually looking at the use of tranexamic acid in women on anticoagulation for control of heavy menstrual bleeding. Very excited to see the results of that study. In clinical practice, I do this from time to time if I'm having difficulty or patients prefer really to avoid other options. I do like to avoid it at least in the first month, I would say, after a VTE, because remember that while it may not cause clots, it does impair fibrinolysis, and we do want to see some clot breakdown in patients who have fresh clots. So procedural therapies are an option if other options fail. And primarily we say that because, well, first of all, there's of course risks associated with procedures, but also any of these would prevent any future pregnancy. With a hysterectomy, of course, because you could not become pregnant after that. With the other options, because they can lead to bad pregnancy outcomes. So high quality contraception or even permanent contraception are required in patients who undergo endometrial ablation or uterine artery embolization. So again, these are only for women who have completed childbearing. So what about anticoagulation modification? I think it's not unreasonable to consider a trial of an alternative anticoagulant. Certainly would not recommend stopping an anticoagulant because of heavy menstrual bleeding unless it was really a life-threatening bleed. Dabigatran and apixaban seem to have lower rates of heavy menstrual bleeding compared to rivaroxaban based on the data that we have available. Whether or not this will actually reduce heavy menstrual bleeding, I think the jury is very much still out on that, and we need more data. But it is something to consider having in your toolkit if you're having trouble controlling heavy menstrual bleeding in these women. There's no data right now on temporary dose reduction. I know that that is a method that some experts use. I think it's, we don't have any evidence to say it's good or bad. I think it's something to consider and have really good risk-benefit conversations with patients about. Although in a woman who is on indefinite anticoagulation, definitely there are data that support using prophylaxis doses once you get past 6 months. And I think that would be very reasonable to try and see if that influences heavy menstrual bleeding in a woman on indefinite anticoagulation. So what about when you're stopping a DOAC in a menstruating individual? So again, you're going to want to discuss post-discontinuation contraception. And if you have a woman who is continuing on OCPs, or any estrogen-based contraception, I do like to stop that at least a month before I stop anticoagulation, because the risk associated with estrogen does continue for quite some time, even after the estrogen is discontinued. So about that 2-month mark is a really good time to try to switch for the patient and see how they do. I like to get new baseline imaging if it's a DVT. I think that's, a general recommendation, but particularly, if you have a woman who perhaps you put a Mirena in her, she experiences swelling off anticoagulation, she comes in, she gets an ultrasound. Sadly, I have heard some doctors blame, VTE on Mirena, which really the data don't show as true, and that woman might get that contraceptive option taken away from her just based on residual clot. And so I do especially like to do this in my women who are on anticoag or on contraception, and also if they become pregnant in the future, it's also helpful to have that baseline. I always do preconception counseling at this point, not terribly thorough, but I do say, you have a pregnancy in the future. Depending on the circumstances of your clot, you very likely will need anticoagulation prophylactically, if not during, then at least after pregnancy. So make sure they're aware of that. And I like to discuss future sources of estrogen exposure, both future pregnancies, future contraceptive methods, and also if hormonal therapy comes up in the future, just make sure the patient's aware of her options and the risks with each of those. So back to our clinical case. So we have a 27-year-old woman on rivaroxaban with very heavy periods and symptoms of iron deficiency. And I can't tell you how often I hear this, even among friends my age on social media, young women complaining about restless leg and eating ice, and that's perhaps their only symptom. And it really often does happen to be associated with iron deficiency. So don't ignore the restless leg. She was, again, taking OCPs for heavy periods prior. She reports changing her pad or tampon hourly. When you take her menstrual history, she's bleeding for 8 to 10 days. She's soaking through clothes and sheets. So all of this is really consistent with heavy menstrual bleeding in this patient. And she denies a desire to become pregnant in the next year. And that's a useful question to ask patients when you're considering hormonal options. So in this particular patient, she did have quite an impressive anemia, a hemoglobin of 8, a low MCV, and a very low ferritin. So an urgent referral is placed to gynecology for a levonorgestrel IUD placement, and IV iron is initiated. So we'll see her back in clinic 1 month later, which will be 3 months after her initial event. She reports having frequent but lighter bleeding. This is very common in women who have the levonorgestrel IUD placed. Many of them, even up to 40%, will eventually have amenorrhea, but it can take time for that to develop. And in the meantime, irregular bleeding and frequent bleeding is not uncommon, but as long as the overall blood loss is less, that's okay. We tell them to hang in there and see how it is at 6 months. Repeat ferritin is robust after her IV iron. Rivaroxaban is discontinued. A new baseline ultrasound is obtained. We discussed the need for low molecular weight heparin with pregnancy in the future. And in a patient like this, I would plan a 6-month follow-up as a hematologist, not because of the anticoagulation issue, but to see how her periods have leveled out after the Mirena and to make sure that she doesn't need additional iron therapy at that point. So things that I hope that you take home from this talk: heavy menstrual bleeding is common, it's under-recognized. Make sure you're asking about it at every visit. I can't tell you how many anticoagulation clinic notes I've looked at in menstruating women where they say no bleeding, and there's not no bleeding, she's having periods. It just, they may be normal or abnormal. Hormonal therapies are first line. It's okay to continue estrogen on anticoagulation. Just make sure to stop it before discontinuing anticoagulation. Make sure we're evaluating for and treating iron deficiency in these women. And don't forget the importance of discussing contraception and pregnancy planning. A lot of these women get the message that they can't be on any hormonal contraceptives when they're taken, when they first present with their clot. And it's important to educate them on the differences and the nuances of their options. Thank you very much for your time. This is my email. I'm always thrilled to talk about women's issues in hematology and anticoagulation. So feel free to reach out to me if you have any questions I can answer. And thank you for your time and attention.
Thank you very much. That was an outstanding, very clear, systematic and methodical talk. So really, thank you. I have to say, this isn't a group of patients that I see often, but when this problem occurs, I do feel sometimes that I don't really know what to do, right? Because you're always trying to balance the risks in multiple ways, and I have to say also, it is very surprising, how many women themselves are not aware of whether their periods are heavy, and because most of us don't sit around talking about that, and we only reference it to what mom or aunts or sisters might have, and then it's possible that the entire family has a history of heavy menstrual period as well. So that is something sort of I certainly learned. So we do have a few questions. The first one, so for Dr. Samuelson Bano, in patients with heavy menstrual bleeding on anticoagulation who prefer an IUD, right? Do you typically hold or resume the DOAC similar to a low risk procedure? All right. And if so, do you suggest the procedure to take place at least 1 month following incident thrombotic event? So actually multiple things packed in that question.
Those are great questions. So we don't hold anticoagulation for IUD placement. It's actually a very low risk procedure, so easily done in the office. That's a great question about holding it. It's a little bit, honestly, usually takes about a month for them to get into the gynecologist to have it placed anyway. I think the more important thing is to get control of the periods. There is some degree of systemic absorption with the levonorgestrel IUD, but as long as a patient is on therapeutic anticoagulation, I think it's okay to put it in whenever you're able to get it in.
Thank you. Second question, related. So in a woman with an acute DVT and a known history of heavy menstrual bleeding, and more likely will continue, will get worse on anticoagulation because you're going to put her on a DOAC. Would you recommend starting estrogen therapy instead of TXA, or is there do you actually have a preference, or which would actually make sense?
That's a good question. Usually in the setting of an acute DVT, we'll give a call to a gynecologist and they'll probably get started on a progestin pill kind of temporarily. It's not great contraception, but it can be started quickly and it can control that heavy menstrual bleeding until we can kind of get her in for a different option like an IUD or something else. I think, it's a tricky question about starting estrogen right at that moment. I wouldn't start it before anticoagulation was therapeutic. So I think starting it kind of in those first 4 days before you reach steady state could potentially be a little bit tricky. Because you're adding a new risk factor on top of whatever risk factor already contributed to the DVT. So in that setting, I would probably start with progestin therapy. And again, the TXA just to avoid in that first month to allow fibrinolysis to occur. There's no data saying that, you're going to have more post-thrombotic syndrome if you give TXA, but I don't think we'll ever have good data for that. So that's just my personal practice.
Thank you. So a question for Dr. Castellucci. So your COBRA trial basically follows patients, as you say, for 3 months. And then after that, I just want to, again, clarify. So are patients basically, is it up to the discretion of their physician whether, they continue on that, DOAC they were randomized to? Are you following that immediately because, that could perhaps have an influence on your outcomes because you are following the patients for, I think, the additional month after, right? Or maybe I'm confused.
Yeah. Thanks for that, Dr. Lee. So we are following only until 3 months. And so anybody that is felt to need longer term anticoagulation, so for unprovoked clots, for example, and the minimum treatment for some would be 6 months. In general, what I've seen is that participants continue on the same anticoagulant that they were randomized to. There is certainly the option of switching, but I don't see that happening very commonly. We are only following until the 3 month mark and up to 2 weeks after is sort of our threshold for the follow-up time period to capture anything that may happen up to 3 months after or 2 weeks after stopping the anticoagulant if they are to stop for provoked clots, for example. But as you know, many patients often continue anticoagulants long-term, and if they've done well on their initial anticoagulant, I think many will continue on whatever regimen they've been initially randomized to.
Thank you. So I think I have another question for Dr. Bano. So if a woman has an OCP-associated VTE and completed their course of anticoagulation, do you recommend that they delay becoming pregnant for a period of time? So for example, 1 year.
No, not typically. We know, of course, the risk goes down over time, and it usually takes a while to become pregnant when patients start. So even if they started trying at 3 months, it's unlikely that they'll be pregnant immediately. So I think it's probably okay to start at 3 months. Of course, the farther you get out, the lower the risk will be. But I, do make sure that the patients are aware that they are going to have to go on low molecular weight heparin. And it's a whole other discussion about whether you start with the first pregnancy test or whether you start after the ultrasound, but I don't think we have time for that today. But I think it's okay to try within that year as long as they've made it through their 3-month period of anticoagulation.
Now, and I'll throw this question at both of you then. So Dr. Vano, you mentioned that you would routinely do a baseline ultrasound at the end of 3 months just to document, whether there's residual thrombosis, so you can certainly make a diagnosis easier in the future. Is this, in your experience, right? Do most of the patients have residual thrombosis or most of them don't? Is this type of thrombotic event or I guess basically in terms of, maybe I'm mixing up my own question here, but say just different types of thrombotic events, right? And women with heavy menstrual bleeding, you're doing a sort of a new baseline ultrasound. Have you noticed any differences amongst different types of thrombotic events that may be associated with a higher likelihood of having residual thrombosis? I know this is kind of a little bit outside of this, but even just say, if you have experience with low molecular weight heparin or warfarin, like, does that seem to vary?
Not in my experience. I can't say I was necessarily paying attention to that specifically, but I don't think so. I mean, the fibrinolysis is the body's own process. So I would assume it would be more patient dependent than drug dependent, and also dependent on the size of the event, how long it took us to diagnose it. So I don't think so, but I kind of tell the patients, particularly my anticoagulated patients, I don't care if you still have residual thrombosis. It's fine. I just don't want that to get diagnosed as a new thrombosis down the road. And of course, even with that, they often still become anxious, but better they be anxious than unnecessarily anticoagulated. So that's my thought.
Mm-hmm. And Dr. Castellucci, what about your experience?
Thanks. It's a great question. So I think the sort of general rule that I tell patients is, as Dr. Samuelson said, it's your own body that breaks down the clot. And so about half of patients, it will be done very efficiently and get rid of all the clot. And then the other half will have some residual thrombus left over. And I describe it as a scar that's left over in the vein, and it's stuck to the wall of the vein and it's not going to move. But we do it for the purpose of being able to compare, so that in the future, if they come back with symptoms, even of PTS, and somebody does another ultrasound, we can compare those images and see that it's not a new clot and that it was the same distribution as the baseline imaging.
Perfect, thank you. Another question that's just come in. I think you covered this in your talk, but perhaps the subdermal implant are safe with anticoagulation. But what about skin patch?
So I'm assuming that we're talking about for birth control. So the estrogen progestin skin patch is not, it does increase the risk of VTE. So probably safe to continue on anticoagulation, not safe without anticoagulation. If you're talking about transdermal estrogen only, interestingly, transdermal estrogen does not appear to increase the risk of clots. And so we see that primarily as hormone replacement therapy. But also some with our transgender population, we can use estrogen patches in them. And of course, there you're usually not having to worry about unopposed estrogen. If you're using it for hormone replacement therapy, either the patient needs to not have a uterus or there needs to be some other exposure to estrogen. I've seen gynecologists do, for example, Mirena placement and transdermal estrogen. So the patient gets the benefits of the estrogen, doesn't have an increased risk of VTE, and doesn't have an increased risk of endometrial cancer with unopposed estrogen. So I'm not sure which of those you were asking, but I tried to answer both.
No, that's fantastic. And, as we go on, there are so many sort of variations. Sometimes, again, if you don't think about in the area, they're just, again, patches. When we say patches, well, which patches are you talking about, sort of, right? I have a question about the woman and crash trials, and maybe again both of you. The dose of tranexamic acid used in woman and crash 2, were they similar or not? And is that the dosing that you would recommend to help with heavy menstrual bleeding? And Dr. Castellucci, are you allowing patients to use tranexamic acid in your study?
Yes, great question. So I'm not exactly sure of the regimen used in the women's study. In CRASH, it was a gram intravenously, and I think up to Q8 hourly, if I'm not mistaken. And I'm not sure, Bethany, if you know if that was also the same regimen for the women's study. But yes, I do. I often give women with history of heavy menstrual bleeding a prescription at the same time for tranexamic acid with their anticoagulant. And I tell them to tell their pharmacist that I said it's okay that they take both, because I've often heard from patients that their pharmacist said that they can't take tranexamic acid because it's going to cause clots. So I often give it at the same time, and I tell them that it's fine to take both. And we do capture it in our concomitant meds history for the COBRA trial. So we are capturing that information, yes.
Okay, all right. And so, sorry, Bethany, do you know the dose in tranexamic acid in women's?
It was 1 gram IV, and I do believe they could repeat it every 8 hours. And that's going to be bioequivalent to the 1,300 milligrams PO TID that we would use in patients with HMB, with heavy menstrual bleeding. The only time there's ever been a study that I'm aware of that maybe showed a signal of VTE with tranexamic acid was the HALT study, and they were using 1 gram IV, but you could do it 4 times a day instead of 3 times a day. So that's different dosing than we use in the other patient populations. So I want to get a t-shirt that says TXA does not cause VTE and wear it everywhere. So, and share it with the pharmacists and the patients and everybody. I do the same thing you do, Dr. Castellucci. Have to educate patients that if the pharmacist says it, if the internet says it, don't listen, just listen to me.
No, great point, actually. I mean, we still have pharmacists who also tell patients, who's on warfarin to not take vitamin K, products or leafy green vegetables, and that just causes more problems. Well, I have to say, both of the talks have been outstanding. I really enjoyed our Q&A as well. I hope everybody's learned as much as I did, again, about this issue, and very, very common. Obviously, half of our population with thrombosis may be dealing with this. So for everybody who attended, remember that the seminar is qualified for the Royal College MOCOP points, and I just want to again invite you all to return in May for our actually last seminar for the year, and this will be looking at diagnosis of thrombosis, specifically in terms of algorithms as well as D-dimer. So again, it will be a great talks, and thank you both of you, outstanding. I really, really enjoyed it, and stay safe, everyone.